Welcome, my dear colleagues, to my YouTube channel. This is Dr. Mustafa Mahmoud. Today, our presentation will be about obesity or adiposity-based chronic disease. Please don't forget to like, comment, share, and subscribe to my YouTube channel for more video updates. Our agenda in part 1 presentation will cover the definition, classification, epidemiology, etiology, pathophysiology, and comorbidities of obesity. In part 2 and 3 presentation, clinical picture and management of obesity will be covered. Obesity is defined as excessive or abnormal accumulation of fat or adipose tissue in the body that may impair health. People are considered obese when total body fat exceeds 25% for men or 33% for women of their body mass. Classification of obesity. Elevated body mass index or BMI, which expresses body weight in kilograms as a function of body height in square meters, as a surrogate measure of body fatness. This BMI is the most widely accepted definition of obesity. The BMI of 25 to 29.9 defines overweight or pre-obese, while the BMI of 30 or more defines obesity. The degree of obesity can be further subcategorized into Class 1 obese, when BMI of 30 to less than 35, Class 2 obese, when BMI of 35 to less than 40, and Class 3 obese, when BMI more than 40 kilogram per square meter. Epidemiology of obesity. Worldwide obesity has nearly tripled since 1975. In 2016, more than 1.9 billion adults were overweight. Of those, over than 650 million were obese. 39% of adults were overweight in 2016, and 13% were obese. Overweight and obesity are the fifth leading risk for global deaths. At least 2.8 million adults die each year as a result of being overweight or obese. Etiology of obesity. The etiology of obesity can be classified as primary or secondary obesity. The primary obesity, which represents more than 90% of cases, is due to an imbalance between energy intake and energy expenditure. This imbalance leads to excess fat accumulation. Secondary causes of obesity. Such secondary causes of obesity can be genetic, which may be monogenetic or polygenetic. In the monogenetic obesity, which caused by mutation of single genes, for example, number 1, leptin. Leptin is a peptide hormone that regulates balance between energy intake and energy expenditure. Leptin or leptin gene mutation leads to deficiency of leptin hormone or its receptor, resulting in leptin deficiency or leptin resistance. Such leptin abnormalities leading to obesity. Number 2, mutation of propionic gene leads to propionic deficiency. The deficiency of such peptide leads to hyperphagia, lowering resting metabolic rate and severe obesity. Number three, melanocortin 4 receptor gene. That gene codes for melanocortin 4 receptor protein, which plays important role in the energy balance and food intake behavior. Mutations in such gene leads to melanocortin 4 receptor deficiency and obesity. Number four, the fat mass and obesity associated gene. Such gene comes in two forms: high obesity risk variant and low obesity risk variant. If the patient inherited two high risk copies, the risk of obesity will be increased to 70% compared to inheritance of two low risk variants. In polygenic obesity, which results from a member of non-epistatic genes that interact additively to influence a phenotypic trait contributing to multiple gene inheritance, as seen in genome-wide association studies. Secondary obesity can be syndromatic obesity, which caused by chromosomal rearrangements. The predominant phenotype is obesity, plus other associated features like mental retardation, congenital defects, dysmorphism of limbs, endocrine or facial dysfunction, like Prader-Willi syndrome, WAGR syndrome, Prader-Willi syndrome, Fragile X syndrome, Cohen syndrome. Secondary obesity can be due to endocrine disorders like Cushing syndrome, insulinoma, polycystic ovary syndrome, growth hormone deficiency, and hypothyroidism. Some neuropsychiatric disorders can be also associated with obesity, like hypothalamic obesity due to trauma, tumors, or neurosurgery. Also, obesity may be associated with affective disorders like major depression or bipolar disorder, an anxiety disorder like panic disorder, pink eating disorder, attention deficit hyperactivity disorder, and alcohol dependency. Secondary obesity can be also due to some medications that cause weight gain, as tricyclic antidepressant like imipramine, amitriptyline, antidiabetics like insulin, sulfonylurea, glenide, serotonin receptor antagonist like bezotifen, H1 antihistamines like cyproheptadine, and steroids like oral contraceptives and glucocorticoids. Pathophysiology of human obesity. In this video, we will focus on the pathogenesis of the primary obesity. Body fat increases when energy intake exceeds the energy expenditure. On the long term, a positive energy balance will result in obesity and resetting of the body weight at increased value. When energy consumption exceeds energy expenditure, 60 to 80% of energy excess will be stored as fat. This process of energy balance is regulated by central and peripheral mechanisms. The balance between orexigenic and anorexigenic neurons of the hypothalamus by circulating hormones and nutrients controls food intake and thus energy intake. The hypothalamus regulates the production of neuropeptides like ghrelin from stomach, leptin from adipose tissue, and neuropeptide Y from the hypothalamus, which contributes to regulate appetite. Low levels of glucose, fat, amino acids increase levels of ghrelin and decrease leptin. Ghrelin causes release of neuropeptide Y from the hypothalamus. The released neuropeptide Y works to stimulate food intake, decrease latency to eat, increase motivation to eat and delay satiety, promote energy storage in white adipose tissue and inhibit brown adipose tissue activation. The food intake restores deficient nutrients, which decrease ghrelin and causes leptin release from adipose tissue. The released leptin acts on the hypothalamus to reduce neuropeptide Y release. The dysregulation of this system leads to overweight and obesity. Energy expenditure and obesity. In obese people, the higher energy expenditure is mainly a consequence of higher resting energy expenditure compared to lean people. The resting energy expenditure was significantly higher in obese individuals, about 360 kilocalories per day higher. The feedback systems worked by driving the body weight back towards the predetermined weight or fat mass through modulation of satiety hormones, altered food preferences, and behavioral changes. We can understand that obesity protects obesity through altered regulation of caloric intake and set point mechanisms which help to maintain high equilibrium body weight. Obesity-related comorbidities. Obesity is a systemic issue and as a result affects multiple organ systems. Those comorbidities with their respective organ systems are respiratory comorbidities like obstructive sleep apnea, obesity hypoventilation syndrome or Pickwickian syndrome, DVT and pulmonary embolism, cardiovascular comorbidities like ischemic heart disease, essential hypertension, atrial fibrillation, and congestive heart failure. Central nervous system comorbidities like stroke, idiopathic intracranial hypertension. Malignant comorbidities like postmenopausal breast cancer, colorectal, endometrial, renal, esophageal, pancreatic, liver, and gallbladder cancers. Psychological comorbidities like depression. Gynecologic comorbidities like infertility and polycystic ovary syndrome. Male reproductive comorbidities like hypogonadotrophic hypogonadism. Endocrinal comorbidities like type 2 diabetes, prediabetes, metabolic syndrome, and dyslipidemia. Gastrointestinal comorbidities like non-alcoholic fatty liver disease, gallbladder stones, and reflux esophagitis. Musculoskeletal comorbidities like osteoarthritis. Cutaneous comorbidities like intertrigo, acanthosis nigricans, and hirsutism. Surgical comorbidities like increased surgical cardiovascular risk and infections. Thank you for watching. I am willing to see you again in the next presentations about obesity clinical picture and management. Until next time, goodbye.